I'm Jim Mold, and I'm speaking today with Pauline Boeckxstaen from the University of Ghent, where she's a family physician and assistant professor in the Department of Public Health and Primary Care. Pauline and I met, I don't know, 6 or 8 years ago. Um, I was reading the program for a NAPCRAG meeting, and I saw that someone was presenting on goal-oriented care. And we met around planning for that conference. She was grateful. She was graceful enough to let me help plan for that particular presentation. It's good to see you, Pauline.
Yeah, good to see you too. For me, it was a big honor to work with you at that point because I had read your seminal paper on goal-oriented care from 1991. That's a point where I was 10 years old. It was put on my desk by my former supervisor to build my PhD on multimorbidity. So it was my honor to work with you when we finally met at NAPCRAG.
So aside from just wanting to talk to Pauline, I think that Belgium is going to show the way for the rest of the world. I think for a combination of reasons, I think Belgium is ahead of most other countries in implementing goal-oriented care. So I'd like to ask Pauline to tell us a little bit about how that came about and what's happening right now in the Flanders part of Belgium.
Mhm. Okay, so I think I agree, Jim, that that's an important story to tell. In Flanders, there has been a major primary care reform that started, well, more than 10 years ago, but it took some pace about 10 years ago. And then at some point, Flanders has been divided into 60 primary care zones that actually built a meso level for individual primary care professionals, such as family doctors, nurses, physiotherapists, social workers working in single-handed practices or working within specific organizations. So when the meso level for primary care was built, this was built together with a vision for primary healthcare and primary care in general. And in that vision, in that shared vision for primary care in Flanders, goal-oriented care has been put on the policy agenda by some important voices in Flanders who have been building this primary care reform at the policy level. So one of these people was Jan de Mazenier, my former head of department, who has been very important to put goal-oriented care on the policy agenda in the context of this primary care reform. And this actually has led to the fact that in this primary care reform, goal-oriented care is high on the agenda of the boards of these different primary care zones, which means that interprofessional teams are eager and willing to build goal-oriented care into their program of work. So, and apart from that, I think that goal-oriented care is something that is tempting to professionals who want to shift the focus from what's the matter with the patient to what matters to the patient, and especially in this reform where we go from the medical focus to interprofessional care, where doctors work with nurses and physiotherapists and social workers. I think goal-oriented care is very tempting because it also levels out hierarchy. It gives interprofessional teams a common language that helps them to get rid a little bit of their own professional perspective and take the focus from their own perspective to the person they're caring for as interprofessional teams. So I think both top down and bottom up there was a way where goal-oriented care was tempting to all the stakeholders.
Talk to me a little bit about the common language that you've developed.
I think at first when we worked on trying to put goal-oriented care or trying to translate the concept of goal-oriented care into clinical practice, we have worked with ICF, the International Classification of Functioning and Disability, because it helped to professionals to focus from the disease to the person by focusing instead of focusing on the disease, focusing on the functional status of the person. And that was done from a biopsychosocial point of view. But so that was our first attempt to find this common language. But what we did see is that it didn't really help us to go to the goals of the patient. It helped us to take a broader perspective on the patient. It helped us to look from a common lens, take a common lens on the patient's situation, but it didn't help us to get to the goals of the patient. So that was an attempt in common language, but it didn't really work out. And I think that the common language actually has taken big steps forward when we have co-designed an interprofessional training program on goal-oriented care, because we had the concept of goal-oriented care the way you have described it, and the way others have picked it up in other wording and other ways, like Marie Tinetti, but we did not have hands-on ways for professionals to work with this as interprofessional teams. So when I was giving lectures or trainings, I often got the comment that it was too medical, even though this was not the way I looked at it, but still it was too much from the medical perspective. And I think by co-designing the training program with people who have developed different strategies to have different conversations with patients, and we had different tools, a goal finder, a clever protocol. Zorga Esperanto, you have met Bartel Tour, who has also helped us to find ways to help different providers think about the difference between goals and strategies. And I think by working together with different types of people from different backgrounds and different contexts, we have developed a common language where we disentangle life goals, care goals, and strategies. And when professionals look at a complex patient situation or a complex situation of a person they're taking care of, they often step into the pitfall of trying to solve the problem, trying to rescue the patient, and they come up with different strategies, but they make the mistake that they translate the strategy into a goal, and then there is a resistance by patients, primary caregivers, other healthcare professionals, and when they're really stuck in a situation, for me, that common language helps them to see, no, this is not a goal, it is a strategy. It is my strategy because I want to solve the problem, or I want to rescue the patient, or I want to decrease autonomy of the person because I have a conflicting value or norm. And when they do this as teams, especially in heart sync patients, in complex situations where everything is stuck, they almost coach each other to take a step back and look at what outcomes are actually meaningful in this case, what are, in our Flemish language, care goals, and what are life goals. And then the care goals are like my responsibility, the things that I want to take care of, but they are not always meaningful for the patient. So when we look at the life goals and how they are at conflict with the care goals, they are often less frustrated, and they are less imposing on the person. So a very clear example for me is an older couple living at home, and the older man is having dementia, Alzheimer's disease, and he is having some behavioral issues. And we see that his wife is struggling to take care of him. And then often professionals propose the strategy of taking the person, the man in this case, to a daycare center so that the wife has less hours to take care of him during the day. But the strategy of taking the man to a daycare center is in conflict with the life goal of the couple to be together. And when the strategy is translated to a goal, like we need to get this man into daycare because the wife needs to have a decreased burden of care, you have conflicting goals. And the care goal is getting the person to a daycare center, but this is not a goal, it is a strategy. And when professionals see that their strategy is a strategy and not a goal, they take a step back, and resistance and frustration decrease. And I think that that is the point where in interprofessional training on goal-oriented care, professionals find each other in that common language or common perspective, common vision of meaningful care.
I think it's so interesting that you've come up with this term of care goals, which is part. I mean, and then you've also said that sometimes those are actually strategies, and I would say that they also can be objectives. That is steps on the way to a goal. So basically, you're separating out the strategies that the patient will employ and the strategies that the care team will employ. But there is no word for objective in Flemish.
No, I agree. We only have the word goal.
Right.
We don't have the word objective. That is a problem.
Well, it's just once I understood what you were talking about, it was fine. But I was trying to figure out why you had to have two different kinds of goals. So how have people reacted to this? I mean, have the teams embraced this? I think, and how do patients respond?
Yeah. So in the implementation of goal-oriented care in the past couple of years, we have chosen to work with the innovators and early adopters to help us build the knowledge. So I need to be honest that the people in these interprofessional training programs are the ones who are somehow interested to give it a go and to try. So if you look at diffusion of innovation, if goal-oriented care would be an innovation, we can debate about that. But in the diffusion of innovation theory by Rogers, you have the laggards, but we have chosen not to invest or work with the laggards, but to build the knowledge with the people who are somehow on board or eager to try this. This means that they are on board and eager to work on person-centered care, on working towards what matters to patients, but also on working collaboratively. In this group of people have accepted it, I think, and worked with us to build the knowledge. They have also identified with us some barriers where sometimes in systems they report, or in specific organizations they report lack of time or lack of time to work together. So of course there are barriers, but we have done an ethnography study recently in trained professionals who have done the interprofessional training program. And we have done some very, very nice observations that don't necessarily indicate that goal-oriented care takes more time. And this study is part of a PhD that is currently being finalized by one of our younger researchers. And it actually has identified some new core competencies to provide goal-oriented care for professionals. And I think if we can further develop these competencies into training programs for students and professionals in the field, I think we can further build on the implementation of goal-oriented care and overcome barriers in the system just by training professionals, increasing their competencies to do this in their clinical work on a day-to-day basis without needing necessarily more time or more resources. What I do think is needed is time and resources for interprofessional case collaboration, and for me, not necessarily interprofessional team meetings for every patient that has more than one provider involved, but interprofessional case collaboration at specific point in times where people develop a common vision, a common way of working in complex patients, and when they have this system of interprofessional training or interprofessional intervention built into their year, I think it will translate back to the individual patient situations, because professionals will develop normative integration and provide more integrated care when they are trained together and when they have participated in intervention programs on complex patients.
How can we take what you're learning in Belgium and move and spread it to other countries? What I understand some of the obvious barriers, but I mean, you've developed a training program that other people could benefit from.
Mhm.
I suspect it's all in Flemish, but is there some way to make that available?
I think that the knowledge that needs to be that we need to train professionals, it's not rocket science. And I think it's easily translated into English or into other languages. I think the most important context you need to create is you need to create a context where professionals can find each other to work on these complex heart sink patient cases by using the knowledge on goal-oriented care that can be provided. But I think that the strength is that local trainers who are part of a local network take the knowledge of goal-oriented care and spread that knowledge to their own teams in their own networks. So for me, the implementation of goal-oriented care goes hand in hand with building local primary care networks. And some countries have these primary care networks, and sometimes they are even stronger than the ones that we have in Belgium. But for me, the key is having professionals learn from each other. I remember at one point in an interprofessional training on goal-oriented care that the social worker said to a family doctor, "You expect this from you as a family doctor in a 15-minute consultation, but this is something that I can handle, but I will have 3 home visits of 50 minutes to achieve what you aim to achieve in a 50-minute conversation." So they really work together, and they also help each other to think about, okay, what is really meaningful here? What do we really need to take care of, and what can be left a bit behind? And for me, it often leads to working less hard and maybe doing less. But that is something we need to prove or demonstrate that it actually could be a solution to the lack of resources. But that's something that's another debate, I think.
And I wish we had more time to talk about it. I understand you're very busy with administrative work, but I hope you'll let me engage with you on email because I'd like to see some of what you learned come to the United States. Thank you again. Have a great day. I guess it's night there.
Almost, yeah, but still bright. Well, bright sunset actually, almost sunset.
Thanks, Pauline.
Thank you for your time, Jim. It was happy. I'm happy that we had this conversation, and looking forward to working with you in the future.